So very good evening, everyone. Today we are starting our Uromet 3.4, which is the continuation of previous prostate cancer 1 episode. As our expert panel, we are having a guest speaker today, Dr. Nuraj Joseph, who is consultant clinical oncologist who has special interest in this prostate cancer management in Sri Lanka. And he was a continuous support for this Uromet program. He was in previous Uromet program as well. Then from our spouse paternity, we are having Dr. Manjula Vijayawardena sir and also Dr. Sagara Kumar sir from UK. And we are having Gauriban sir as our coordinator of this event. So today first speaker will give the outline of prostate cancer management related medicine management. So during our clinical practice, we will come across patients who are not willing for the surgical castration. And there are some instances where we will get a patient on first presentation as a metastatic prostate cancer with oligomets or multiple bone mets. And there are some instances where might be a bone mets, or there can be a lymph node biopsy which might come as a prostate adenocarcinoma. So I'd like to give space to Dr. Madhushanka Ekanayaka, Senior Registrar from Teaching Hospital, Kandy, to discuss broadly about this medical management of prostate cancer. What are the clinical instances, what are the main drugs, and their physiological and pharmacological basis, and then especially considering about the level of evidence and trial evidence, and discuss on further management. You have only 15 minutes. It's a broad topic. It's over to you, Dr. Madhushanka Ekanayaka. We will inform you when 2 minutes remaining. Okay.
Good evening, everyone. Dear sirs and my dear colleagues, I will be discussing here the drugs used in prostate carcinoma management, mainly for drugs, their pharmacological action, physiology, and the trials related to those drugs. Before starting to my main individual drugs, I would go through the clinical stages where there are different classes of drugs they are used in various clinical stages. The management of the prostate cancer involves the different pharmacological strategies that depends on their clinical stages. Here, main stages are the localized prostate cancers, that is stage 1 and 2 disease, and the locally advanced prostate cancer stage 3, metastatic and non-metastatic prostate C, and metastatic and castration-resistant prostate cancer, and also the following the management of the bone metastasis and the related drugs. In localized prostate cancer, that is stage 1 and 2, we mainly use the androgen deprivation therapy in conjunction with the radiation therapy with the patient who have intermediate and high risk localized prostate cancer. And it has shown that with the URTC randomized control trial by BOLA, it improves the disease-free survival and overall survival. I will discuss my individual drugs in my later slides. The locally advanced prostate cancer, we are using mainly the androgen deprivation therapy and anti-androgen. In the metastatic hormone-sensitive prostate cancer, there we are using the anti-androgen therapy with the combinations of chemotherapy and second-line anti-androgen agents for maximum androgen blockade. In the non-metastatic castration-resistant prostate cancer, we are mainly using the second-generation anti-androgen apart from those drugs, and these drugs delays the metastasis and improve the survival. In the metastatic castration-resistant prostate cancer, we use continuation of the androgen deprivation therapy, and apart from that, we use second-generation anti-androgen, the androgen biosynthesis inhibitor, and the chemotherapy, the immunotherapy, radiopharmaceuticals, and special immunotherapeutic agents, PRP inhibitors, such as like drugs. And the management of the bone disease, we use bone targeting agents such as bisphosphonate and the monoclonal antibodies such as denosumab. When going to individual drugs, the main the physiology of the androgen deprivation is that usually our androgen secretion is controlled by the hypothalamus pituitary gonadal axis, where the hypothalamus secretes GnRH, and in response to that, FSH and LH. Mainly the LH stimulate the testosterone secretion. 95% of the testosterone that is secreted by the Leydig cells of the testis And in the periphery, it will convert to dihydrotestosterone, that is the active form of testosterone. And apart from that, the ACTH control mechanism that is involved in the adrenal cortex, 5% of the testosterone is produced. And androgen deprivation we can achieve mainly by the surgical and medical forms of castration. We define the castration levels of testosterone as less than 20 nanograms of deciliter. And in the surgical forms of castration, that is the quickest method to achieve castration, we can achieve less than 50 nanograms of deciliters of testosterone within 8 hours of the surgical castration. So this is the hypothalamo-pituitary gonadal axis and its negative feedback inhibitory loops showing the secretions of the testosterone. So we use various drugs in various stages to achieve the surgical medical castration in this form. So I will discuss the hormone therapy, androgen deprivation therapy. That is any treatment that lowers the androgen activity. Usually, the prostate epithelial cells are physiologically dependent on the androgens, and cancer cells undergo apoptosis with the ADT. But patients with BCL2 overexpression and P53 gene mutations are associated with hormone refractory disease. The main category of drug is the LHRH agonist. The examples are leuprolide, goserelin, mainly used drugs, and their mechanism is initially they stimulate the releasing of the LH, that is luteinizing hormone from the pituitary gland, and it causes some temporary surge in the testosterone production by the testis Leydig cells. And the continuous stimulation desensitizes the pituitary gland and leading to significant drop in LH and testosterone levels. This results in chemical castration and reducing the androgen levels. We can achieve castration levels within 2 to 4 weeks of starting the LHRH agonist. And the problem with this LHR agonists are the flare phenomenon. That is, there will be an initial surge in testosterone, and it can lead to spinal cord events, fatal cardiovascular events, bone pain, bladder outlet obstruction, or ureteric obstruction due to acute prostatic events. And we need to carefully monitor those patients for symptoms such as bone pain, urinary obstruction, and neurological symptoms. And this risk is higher with the high volume disease. So as a preventive method, we can use temporarily anti-androgens such as bicalutamide during the first week prior and 2 weeks after the starting of LHRH agonist. These are the common side effects: hot flashes, fatigue, weight gain, and increased risk of fractures due to osteoporosis and cardiovascular morbidity. And also there is associated reduced libido and erectile dysfunction. These are the clinical trials and evidence associated with LHRH agonists. The EORTC trial, they have shown benefit, immediate first delayed ADT, mainly the use of LHR agonists in non-metastatic prostate cancer. And SWOG trial, they have demonstrated improved progression-free survival with adjuvant ADT after radical prostatectomy. In the RTOG trial, they have established the efficacy of long-term ADT in combination with the radiotherapy in locally advanced disease. The impact of these trials are they support the use of LHR agonist as the cornerstone of the treatment in advanced and high-risk disease. And in combination therapies, they enhance the efficacy of ADT by combining LHR agonists with the other treatment and achieving the maximum androgen blockade. The examples are the combined with anti-androgen, the adding chemotherapy such as docetaxel that achieve improved survival, and using the novel androgen receptor inhibitors such as enzalutamide, darolutamide in castration-resistant prostate cancer. So next line of drugs are the LHRH agonists. They are degrelix, relugolix-like drugs and work by inhibiting the LHRH receptors in the pituitary gland, which prevent the release of LH and subsequently blocks the production of the testosterone from the testes. And we can achieve castration levels by day 3. So it can be used in advanced prostate cancer, especially when there's rapid reduction of testosterone is needed. The clinical benefits are the management of the acute symptoms in patients with advanced disease, as I mentioned earlier. And we can avoid the tumor flare. There is no flare-up phenomena with the LHRH antagonist. And it also has shown, some studies show that the LHR antagonist has no cardiovascular events when compared to LHR agonists, and they can be safely used in pre-existing cardiovascular condition patients. So side effects are that they can have injection site reaction, hot flashes, weight gain, and the potential bone density losses. And there's a risk of metabolic syndrome associated with LHR antagonists. So next drugs are the anti-androgen. They can be divided into steroidal and non-steroidal. Steroidal are the cyproterone acetate, and non-steroidal drugs are the bicalutamide, enzalutamide, and second generation drugs such as apalutamide. And so there are various drug regimes as well. The mechanism is the blocking of the androgen at the receptor level on the cancer cells, and they can be used with the combination of LHR agonists for the castration-resistant disease to achieve maximum androgen blockade. And in side effects are the gynecomastia, liver function change, and fatigue-like symptoms. In the castration-resistant prostate cancer, CRPC, they are disease progression despite, they define as a disease progression despite of the ADT. Here we define the castration-resistant prostate as a less than 50 nanogram of testosterone with the radiological or biochemical progression. They can be that can be due to development of the androgen independent clones, then the overexpression of the androgen receptors, and the intracellular synthesis of testosterone, such as autocrine action of testosterone. So next drugs are the chemotherapeutic agents. They are cytotoxic drugs to kill the cancer cells. The common drugs are docetaxel, and the second generation drugs are the carboplatin. The mechanism is inhibition of cell division leading to cancer cell death. And they have shown that the dose in the Stampede trial, the docetaxel increases the survival by 10 months. Then the clinical use is they can be used in the advanced prostate cancer, often when the hormone therapy is no longer effective. And Stampede trial shows that there is an added advantage in upfront docetaxel as a standard of care. The next drugs are the androgen synthesis inhibitors, such as abiraterone. The mechanism is the inhibition of the cytochrome enzyme involved androgen production by cancer cells. They can be used in the metastatic castration-resistant prostate cancer, and they have improved the survival. Side effects are hypertension, liver function changes, and the fluid retention. They can be used. They are available in the oral form. That is an added advantage, and especially they need to combine with the prednisolone to prevent hyperaldosteronism like symptoms. So next level of drugs are the immunotherapy. They are in experimental level, and there are some of drugs are they are using in the current practice, and there are some trials, ongoing trials, and some have proven benefits. There's significant potential in the future treatment of the prostate cancer. There is a drug called the Sipuleucel, that is autologous cellular immunotherapy therapeutic agent, and they have shown that the extended overall survival in metastatic castration-resistant prostate cancer, and it increases the overall survival in that especially the impact trial that they are shown that the survival benefits of 4.1 months when used with the combined in mCRPC disease. And next generation of drugs are the checkpoint inhibitors, especially the pembrolizumab, that is PD-1, PD-L1 inhibits the immune response and allowing T-cell mediated response. they can be used in the patients who have mismatch repair gene defects and MSI microsatellite inhibitory tumors, especially in those patients. That will be the end of my lecture, and thank you very much.
Thank you, Madhushankar, to stop this presentation well within the time. So I would like to now move towards our expert panel regarding this discussion to move on with the questioning in FRCS and CS exit exam basis. Over to you, sir, Manjula sir, and the Nurad sir and expert panel.
Niranga, do we have a case scenario?
Not for this presentation, sir. For the next presentation, we are having, sir.
Right, Madhushankar. So that's a very comprehensive presentation. Now come to a basic. What is the level of testosterone you would consider as castration? Successful castration. Just to get a ballpark figure.
It's less than 20 nanograms per deciliter, sir. And we as a conventional method, we consider as less than 50 nanograms per deciliter.
Okay. So suppose the patient consents for bilateral orchidectomy. Would bilateral orchidectomy achieve that result compared to the medical therapy?
Yes, sir. It is the quickest way to achieve the castration. Within 8 hours of the surgical castration, we can achieve less than 50 nanograms per deciliter of testosterone.
Right, but not less than 20.
So I'm not sure, but that is the less than 20, yes.
Less than 20, yes. 1 millimole per liter. Right.
Yes.
Okay. Suppose now you have decided to have a radical prostatectomy of patient who is having slightly locally advanced disease. Let's say CT3. Now, if the definitive treatment is radical prostatectomy, is there a place for neoadjuvant ADT?
The trials have shown that in radical prostatectomy, there is no added advantage of using ADT. But if for the locally advanced disease, if you are using radiotherapy, there is the added advantage of using ADT as a neoadjuvant treatment.
Very good. Right. So if it is after radical radiotherapy, how long would this ADT treatment would go on for an effective treatment?
Sorry, sir, I have no idea.
3 months, 6 months, or 2 years? What do you think? Well, there are a lot of studies, but most studies agree.
9 months.
Yeah, 6 months, lot of people would agree, but traditionally, well, I'm open for correction, Nurad. Here we use 2 years.
Yes, it depends on the risk. So if it's intermediate risk, 6 months is enough. And if it's high risk, then we would go for at least 2 years.
Okay, Nurad, you can ask some questions.
Now, about abiraterone, do you know how it is given? I mean, do you know like the dose and sort of how should patients take abiraterone?
So it's available as oral forms. I am not sure about the dose, and it should be given with the oral prednisolone, because it has side effects such as hyperaldosteronism-like syndrome.
Yeah. So is the dose different? So you can give it either fasting or with food. Are you aware of any sort of differences in the doses when you give it fasting versus with food? So
Sorry,
it's
sir.
usually it was when it was licensed, it was given as 1000 milligrams fasting. But later, so when they did the phase 1-2 trials, they found that when you take it with food, actually you can use a lower dose. But for some reason, when they were taking the dose to the phase 3, they took the 1000 milligrams with fasting dose. So that is what got registered. But later there were trials done showing that 250 milligrams, that is 1/4, was also with food. You have to take it with food, is equal to 1000 milligrams with fasting. So that made a huge difference, especially for us countries like ours, where so it brings down the cost by 1/4.
Cost.
So if instead of taking 4 tablets fasting, if you take 1 tablet with food, then you have the same effect. So in my practice, I generally give 250 milligrams with food, because that way we save a lot of money, both for the in the state sector and private sector. Also, patients have to buy it from outside. Sometimes these drugs are not available in the state sector. So if you give 1 tablet, it's obviously 1/4 the price. Yeah. So is there any evidence of so what are the differences between, now you mentioned abiraterone, enzalutamide, and the newer anti-androgens? So are there any differences between these drugs? So
The
the
use
main,
of
yeah, go ahead. Yeah, you were going to say something.
so mainly the use of anti-androgens we can use as a combination therapy for the maximum androgen blockade in castration, the hormone sensitive disease. But in the abiraterone is mainly used for the castration resistant disease, where the testosterone is secreted as autocrine manner. So by individual cancer cells, that is mainly used in
Yeah, no,
castration
I'm
resistant
asking,
disease.
my question was the newer anti-androgens. So you mentioned abiraterone, enzalutamide. So what are the differences between these drugs? Basically, what is the difference between enzalutamide and abiraterone? Apart from the mechanism of action, so clinically, what's the difference that you see?
So the forms of the forms available for the administration, so the oral forms and the IM administration.
No, both are oral tablets. So the difference is that abiraterone, as you said, you have to give it with prednisolone. So enzalutamide, you don't have to do that. Enzalutamide causes more tiredness. We don't know whether abiraterone also causes that, but because you are giving it with prednisolone, somehow the patients don't feel tired so much. Fatigue is a big issue. So patients are better off with abiraterone and rather than enzalutamide. So abiraterone is slightly more toxic to the liver, but enzalutamide also can cause liver toxicity, and we are supposed to monitor liver functions. With abiraterone, there are stricter criteria. You're supposed to initially monitor it every 2 weeks and then every 4 weeks. Enzalutamide, the liver function monitoring is a bit more relaxed. You can do it every 4 weeks initially and then every 2 months. And the main and enzalutamide is contraindicated if you have a history of seizures. If you have a history of, if you're on antiepileptics or you have a history of seizure, then enzalutamide you cannot give it. Abiraterone, again, hypertension, all that are side effects. Enzalutamide, not so much. So for these reasons, in the West, they were using enzalutamide a bit more than abiraterone. But in our setting, abiraterone is now off patent, so you get generic abiraterone. Enzalutamide is still under patency. So although there are sort of generics, it's sort of not FDA approved, and even those generics are expensive because once the drug is under patent, the non-innovator drugs are also expensive. So cost-wise, abiraterone costs about 1/10 the price of enzalutamide. So that's why in Sri Lanka we tend to use abiraterone mostly. But basically, there are two drugs. They are very similar drugs. One more question now. Actually, may not be relevant to urology. Maybe an unfair question to ask from urology. So, but now, can you use, say, a patient? You put the patient on abiraterone, castration-resistant disease, and the patient progresses on abiraterone. Is there any place to switch to like enzalutamide? Basically, can you switch the anti-androgens? at progression. We do that with a lot of other cancers like breast cancer. We will change from the patient progresses on tamoxifen, we change to another drug, anastrozole. But prostate cancer, can you do that with abiraterone and enzalutamide?
I'm not sure, sir.
Yeah. So initially they thought that because the drugs are slightly different, abiraterone sort of works on the synthesis pathway, enzalutamide is a sort of a receptor blocker, but the resistant mechanisms are common. So using either drug, using enzalutamide after abiraterone is not effective, and there is no license indication. You may see some people trying that, but there is no license indication for that. So those are the main differences between sort of abiraterone and enzalutamide. Abiraterone can be used in the, now we are using it in the hormone sensitive phase as well. So the Stampede trial showed that when you add abiraterone to androgen deprivation, regardless of the burden of disease, whether it's oligometastatic or high volume disease, abiraterone will improve survival. So it is now standard of care. Every patient who is fit enough to receive it should get abiraterone along with androgen deprivation. Enzalutamide also is licensed for, so same indication. You can use now abiraterone both hormone sensitive and castration resistant phases. For the Stampede trial, as you know, the Stampede trial included a population of very high risk non-metastatic cancers also, like high Gleason's, PSA more than 20 and so on. Sort of, it's a very high risk category, not just above the ordinary high risk category. And even in those patients, even non-metastatic, very high risk patients, also abiraterone improved survival. In the UK, they did not still approve it, but the trial showed that even in localized, very high risk prostate cancer, abiraterone will improve survival. So when you add it to ADT, so it is it can be used in all these settings. Regarding what are the, I just can't read the agenda. Is there any, what are the other talks?
So we are having 3 more speakers on locally advanced prostate cancer, metastatic prostate cancer, and oligometastatic prostate cancer.
Okay. So then we'll talk about it later.
There,
I just want,
Okay.
Okay.
If Sagar sir is there, sir, we can. If not there, we can move into the next speaker, sir. I think Sagar sir is still not connected, so we'll move on to the next speaker, sir. So our next topic is locally advanced prostate cancer. Okay, so this is a real case scenario. This regarding your presentation. We got a 59-year sexually active SA1 patient who was from Habarana. He is a father of an engineer who had obstructive lux for 6 months duration. But he was treated by a GP from Polonnaruwa with tamsulosin finasteride dose 6 months without doing a DRE or PSA assessment. Then he was admitted to teaching hospital Anuradhapura recently with acute retention of urine, actually during his post-on pilgrimage. Only after that, GU referral was done to the urology clinic. On clinical examination, DRE sphincter was okay with 60 gram nodular prostate, and there was firm to heart suspicious nodule in the right lobe. His PSA value is 12.4, and ultrasound KUBP, there was no upper tract dilatation. As his son could afford, we were able to get multiparametric MRI done. So there was Byrett's 5 lesion in the right lobe with capsular breach. Seminal vesicles and lymph node were not involved. So we went ahead with cognitive fusion trust biopsy. So there was Gleason 3+4, 15 millimeter core, and 3 out of 5 targeted cores are positive from this suspicious lesion. Another Gleason 6, 2 millimeter core was positive when we are doing the systematic left lobe biopsy. His CECD chest abdomen pelvis was normal, and bone scan was not available at Anuradhapura currently. So Tivika, as a day one urologist, so you will guide us through during your presentation on this question. So how will you interpret this scenario, your management plan and follow-up plan? And how will you explain your decision to this patient and his son? And his son is having concern about this level of evidence and possible outcomes of each management option in long run and survival of his father. So over to you, Tivika. You can answer this question during your presentation, and our expert panel will make further questioning after your presentation. You have 15 minutes. Thank you.
Okay. My topic is management of locally advanced prostate cancer. So, according to the definition of locally advanced prostate cancer, if from the staging, if it is basically T3A more than T3. T3, as we know, T3A is involving the unilateral capsule, T3B is bilateral capsule, T3C is if there's involvement of the seminal vesicles, and T4 outside the prostate. And also if there are lymph nodes also positive, then that also comes under locally advanced prostate cancer, provided there are no metastases. So according to the DMK classification, usually the locally advanced prostatic cancer comes under highest group, either high risk or highest risk. So high risk, according to this category, high risk if the PSA is more than 20 and if the Gleason is more than 7, or if it is more than T2C. Highest risk is any PSA level or any Gleason scoring with T3 or more than that and lymph node positive. So that comes under locally advanced prostatic cancer. So when we are dealing with locally advanced prostatic cancer, so how can we diagnose? Diagnosis starting with the TRUST scan that is not that sensitive. So usually we are going ahead with the multiparametric MRI. So in multiparametric MRI, we can locally assess whether there's involvement of the capsule or whether there's an involvement of seminal vesicle. And also we can combine with MRI pelvis. Or if that is not available, if we are not planning any curative management, then CCT abdomen pelvis is the other option. And also because it's a locally advanced malignancy, we had to always exclude the possibility of having metastasis. So there's an indication for bone scan. And more than this investigation, PMSA PET CCT that will provide that has the highest sensitivity and specificity. Actually, it has about 32% increase in the detection of nodal metastasis. So regarding the management, we have so many options. Usually it's a multimodal therapy, not only one option. Having multimodal therapy allows us to have increased overall survival, cancer-specific survival, than the monotherapy. So the multimodal therapy is a radical prostatectomy combined with, it can be combined with hormonal therapy, or radical radiotherapy can be combined with hormonal therapy. And there's a place for adjuvant radiotherapy after the radical prostatectomy. And other options are watchful waiting or hormonal therapy alone. And there are some, according to the recent trial, there's a place for systemic therapy with abiraterone, docetaxel, and so also enzalutamide according to the STAMPEDE trial. So radical prostatectomy, they say even radical prostatectomy alone can result in increased cancer-free survival, at least half of them. And when we are selecting patients for radical prostatectomy, it should be surgically fit, and that means there should be a low volume disease. And if we are planning pelvic lymph node dissection, they recommend extended pelvic lymph node dissection, especially for high risk patients. And also, there was a time in the past, if in locally advanced patients, there was a place for intraoperative cross-section of lymph node. If that comes as positive, then they abandon the surgery. But that is no longer followed now. even in clinically negative but pathologically positive lymph node, by doing radical prostatectomy, there's increased overall survival. So that can be radical. Still, there's a place for radical prostatectomy. And as we already discussed, there's no place for neoadjuvant hormonal therapy in locally advanced prostatic cancer before the radical prostatectomy, but before the radiotherapy, there's a place. And after the radical prostatectomy, we had to look at this pathological criteria to categorize the patients to come for a prognostic stratification. That depends on Gleason scoring and surgical margin status and presence of non-organ confined disease. That means if there's involvement of the extracapsular extension, seminal vesicle involvement, or lymph node involvement, depending on these parameters, we categorize the patients. So after, so as I already mentioned, it's not only monotherapy, usually always better to combine with the adjuvant therapy. Adjuvant therapy can be hormonal therapy or radiotherapy. The hormonal therapy, indications for hormonal therapy after radical prostatectomy includes presence of pathological lymph nodes. So they say the combination of radical prostatectomy and adjuvant hormonal therapy in lymph node positive patients increases the cancer specific survival as well as the overall survival. And they say even and there's a place for delayed treatment if the lymph node pathological specimen, if there's only less than 2 microscopically positive lymph nodes in extended pedophilic lymph node dissection, then you can defer the hormonal therapy and start when PSA rises. What are the indications for radiotherapy after radical prostatectomy? The main indication is that the surgical, if there's a positive surgical margin. So it can be given immediately or delayed as a salvage therapy when PSA starts to rise more than 0.5. And also there are other indications for radiotherapy after radical prostatectomy. That includes patients with higher grade, 3 or more than that, or if there's extra prostatic involvement, or if there's a seminal vesicle involvement, and lymph nodes positivity. These are the indications for radiotherapy, adjuvant radiotherapy after the radical prostatectomy. So again, according to the EU guidelines, if there are lymph node, if there are negative lymph nodes, again, no need to go for adjuvant hormonal therapy. But if there's a positive lymph nodes, or if the patient is having ISUP grading more 3 or more than that, positive margins, then we can give adjuvant radiotherapy. And also, if the lymph nodes are positive, pathological lymph node positive, and there's a place for hormonal treatment. And also, we can also combine hormonal treatment and adjuvant radiotherapy in lymph node positivity. And this is a trial. This is a EORTC trial 22-911. So this compares this selects in the inclusion criteria of patients with T3 tumors and patients with positive margin after the radical prostatectomy. So they were comparing the effectivity of giving radiotherapy immediately after surgery or delayed surgery. And they say the conclusion is by giving immediate postoperative radiation, that improves the biochemical disease-free survival. So this is the trial which is evident for immediate the treatment with immediate radiotherapy after the radical prostatectomy in patients with positive margins. But not only that, we don't have to follow the same thing, but even if there's a positive margin, there's another option is we can follow up the patient with the PSA, serial PSAs. Yeah, if the PSA is increasing, then we can go for a delayed treatment. Coming to the second option, that is a radiotherapy. So radiotherapy is intensity modulated radiotherapy without image guided radiotherapy is the gold standard. So brachytherapy in locally advanced is inadequate. And again, it's not only the monotherapy. By combining with the hormonal therapy, that improves the outcome. And so, as we already mentioned, they suggest long-term androgen deprivation therapy for at least 2 years if we are giving radiotherapy. And also, as I already mentioned, if the patient is having lymph node positive, or if the patients, or if in patients with negative lymph nodes, with if the in presence of high risk factors, that means advanced stage Gleason more than 8, PSA more than 40, then there's a place for intensive modulated radiotherapy. And you can also combine with hormonal therapy as well as abiraterone. And the other option is deferred treatment. So deferred treatment is kind of watchful waiting. Like in metastatic CA, we can go for a watchful waiting, provided PSA doubling time is more than 12 months and PSA less than 10, less than 50, and should be a well-differentiated tumor and who are unwilling to or unable to receive any form of local treatment, then there's a place for deferred treatment. The other options, as the cryotherapy or HIFU, usually focal therapies are used in localized malignancies, but that there's no place in locally advanced malignancies. And so androgen deprivation therapy as a monotherapy can be used. Yeah, it can be used, but they recommend to be used in symptomatic patients, or if the patient comes under high risk category. That means in locally advanced patients unsuitable for surgery or radical therapy, or if the PSA is more than 50 and PSA density is less than 12, doubling time is less than 12 months, or those who are symptomatic, there's a place for androgen deprivation therapy, androgen hormonal monotherapy. It can be used as a immediate therapy or delayed therapy when the PSA rises. Then coming to the other topic is persistent PSA after radical prostatectomy. So what is our target after radical prostatectomy? After radical prostatectomy, we review the patient usually about in 6 weeks time, and we check the PSA. So persistently elevated PSA more than 0.1 nanogram per milliliter, even within 4 to 8 weeks of surgery, means there's a persistent PSA. So it can be from the risk causes there can be a persistent local disease or pre-existing metastasis, or it can be due to the benign prostatic tissue. So how can we deal with these patients? So usually after the radical prostatectomy, doing MRI has a low detection rate. When the sensitivity is low, if the PSA is less than 2. So usually they say PSMA PET-CT has highest sensitivity and specificity. So if the PSA is persistently elevated, we had to go for PMSA PET-CT. And you can see according to the PSA values, the sensitivity also goes up. So how can we manage depending on the patient's the previous treatment, and depending on the patient's high risk parameters, we can either go for a salvage radiotherapy or hormonal therapy. That was about.
Hello, Tilka, you got 2 more minutes.
Okay, then coming to the PSA only recurrence after the curative management. So that was about the persistent elevated PSA. Coming to the PSA recurrence, sometimes after the radical prostatectomy or radiotherapy, there can be a PSA recurrence. So when the PSA, what is the definition of PSA relapse? They say after the radical prostatectomy, more than 0.2 nanogram per milliliter, that means a biochemical recurrence. And after the radiotherapy, PSA increase of more than 2 nanogram per milliliter, higher than the PSA nadir value, means there's a PSA relapse. So again, EUA categorizes the PSA relapse into low risk category and the high risk category. And again, if there's a PSA recurrence, then we had to do the imaging and the staging. But again, after the radical prostatectomy, the sensitivity of the imaging also goes down, and only to pick up the bone metastasis also, the CTO bone scans are not that sensitive. So better to go for colon PET CT. Even colon PET CT has a sensitivity and specificity about more than 85%, but it has a low sensitivity in detecting the bone low sensitivity in detecting the lymph node metastasis. But more than the colon PET CT, then there's something called flucyclovine PET CT that is better than the colon PET CT. But the PMSA PET CT is the best. And how can we manage local recurrence after radiotherapy? And after radiotherapy,
Devika, sorry to interrupt. Your time is over, 50 minutes over. And we have to stop the presentation, go into discussion. Okay. You can rush through the slide and go into the discussion.
so this is about the radical prostatectomy. After if there's a PSA recurrence after radical prostatectomy, so we had to do the imaging and then come to a diagnosis. After radiotherapy, again after radical prostatectomy, the problem is doing MRI and biopsy. That is not recommended usually. But after radical radiotherapy, we can do the imaging and we can also go ahead with the biopsy after radical radiotherapy. Then we had to go for a salvage treatment. And after radiotherapy, in selected patients in high center volumes, we can go for a salvage radical prostatectomy or brachytherapy. And we can also give androgen deprivation therapy provided the PSA doubling time is less than 9 and PSA value is more than 2 after the radical prostatectomy, PSA value more than 1 or PSA value more than 2 after radical radiotherapy. So when there's a recurrence after one treatment, we had to go for a salvage treatment of the other.
Okay, thank you, Devika.
That concludes my presentation. Thank you.
Thank you, Devika. So we will now move into our expert panel, Manjula sir and Urat sir. It's open for the discussion now, sir.
Okay, Tivika, so that is very exhaustive. Now you are doing this PSMA PET, that is the latest kid on the block. So suppose you are planning this radical prostatectomy for locally advanced prostate cancer, and on a PSMA, which you haven't ordered, but the patient has got second opinion and he has got a PSMA PET, which shows a pelvic lymph node, but the conventional MRI scan did not show it. So would that change your decision for radical prostatectomy?
No, sir. Even if the patient is fit and in the presence of positive lymph nodes also, there's a place for radical prostatectomy because that increases the, there's a place because it increases the overall survival, and because of the availability of the adjuvant treatment with this hormonal therapy and other kind of systemic therapy or availability of radiotherapy, we can still proceed with the radical prostatectomy.
Okay, right. So now if there is a positive margin or it's the tumor characteristics are also high risk, now there is a place for starting this post-operative or adjuvant androgen deprivation therapy. So there is an option of delaying the ADT. Why do you think the interest is there to delay rather than to start right away? Why do you think?
Because according to the initial PMSA PET, it was not detected in the MRI, so it was detected in the PMSA PET CT. And I will look at the histology. If the histology
No, it's not the same.
shows,
It's not the same patient. I'm having this hypothetical patient where the MDT has decided to postpone starting ADT. Why do you think MDT would defer starting ADT when the patient is, indicated to have it instead of starting it right away?
This is after the radical prostatectomy.
Yes.
Okay. Yes. Because even if the indication indication for adjuvant hormonal therapies, it's clearly mentioned is in clinically positive lymph node patients. And but if the lymph node is only microscopically positive, we can still defer the treatment and monitor with the PSA.
Why this concern of not giving everybody blanket ADT treatment? Well, to cut it short, it is to, one day the patient will become hormone resistant. So you want to, wait for as long as possible before starting, because in average, in about 12 months use, the patient's cancer cells will become hormone insensitive. So that is a reason to postpone. Good. Nurad, you can ask.
So, going on that same theme, say you do a radical prostatectomy, assume that the nodes are negative and you have a positive margin, and you decide to go on the path, you decide to not to give any adjuvant treatment. When will you, now you talked about salvage adjuvant treatment. So when will you initiate salvage adjuvant treatment? At which point?
I will follow up the patient with because although margin positive, I'm not giving adjuvant radiotherapy at the moment. So I will follow up the patient with the PSA. So then if the PSA is increasing, if the PSA is increasing, usually they say we shouldn't wait up to 1 nanogram per milliliter. The treatment should be started when the PSA is at less than 0.5. So even if there's an increase, preferably preferably less than at the less than 0.5, I would consider adjuvant treatments. And I can also look at the PSA doubling time and the sensitivity, PSA density to decide.
Yeah. So I think, zero, you're correct. So 0.5 you would start. So just because you have, so the radicals trial that they did in the United Kingdom, which was after the trial that you mentioned, the EORTC trial. So the radicals trial, because the EORTC trial, the salvage radiotherapy initiation was, they waited till I think PSA was 2. So that was considered a bit too late. So in the radicals trial, at 0.5, they initiated adjuvant radiotherapy. And by that strategy, 50% of the patients, just because it's margin positive, you don't have to give radiotherapy. About half of the patients, you can avoid adjuvant radiotherapy. Half of the patients, the PSA will still be undetectable. But only about half will progress. And if the PSA is rising, and you have to initiate treatment, ideally before it reaches 1, so 0.5 is fine. Now, so when you're giving radiotherapy, do you give it alone or do you combine it with ADT? I'm talking about the adjuvant setting.
So there's when we are giving radiotherapy, still there's a weak recommendation for combining with home adjuvant hormonal therapies.
So in the radicals trial, they looked at that, and they found that it was a radicals trial. I think you should read about it, even though it's a radiotherapy, since it's post prostatectomy, might be of relevance to you all. So it was a 2-arm random. It was a 2x2, like a factorial design. So they also randomized to. So there was a radiotherapy randomization, and then they had a hormonal randomization. And the hormonal one also they randomized to 6 months versus 2 years. So they found that adjuvant radiotherapy combined with 2 years of adjuvant ADT improved survival. So now the standard of care, most centers would give adjuvant radiotherapy, like salvage adjuvant radiotherapy, when the PSA becomes detectable at 0.5, and you would combine it with adjuvant ADT for 2 years. Now, having said this, there were some problems with the Radicals trial. It did not have many patients with high Gleason score, and also did not have many patients with sort of T3 B. That category was not, it wasn't a well represented. It was those patients were not very well represented in the trial. So it was mostly sort of Gleason's 3+4, that category, with a positive margin. So if you have a high Gleason, some oncologists still feel that you should give adjuvant radiotherapy. That's not, I mean, that's not standard of care, but some centers, particularly in the United States, they give that. Another reason to do that is that if you're relying on the PSA and your Gleason score is very high and your PSA wasn't high, if it's a non-secretor, then you're in sort of difficulty when you use PSA to as the sort of threshold to start to initiate treatment, because the tumor may not be producing much PSA anyway. So because of that, if you have very high Gleasons, some oncologists would still give adjuvant radiotherapy regardless of even margin status or PSA. But that's sort of a bypoint.
Hello, sir.
Yeah.
Hello, sir.
Yeah.
So last time when we are doing this Uromet 3-point tracer, you mentioned about this Tata Memorial POPR trial, sir, regarding this radiotherapy decision. We'd like to get your input on this.
Yeah. So now prostate cancer is one cancer where, you know, from screening to even at the castration resistant phase, lot of controversies, lot of options, and no real sort of, we have a lot of, you know, gaps in the evidence. So so now radiotherapy, when you're giving radiotherapy, there is this issue whether we should be treating the lymph nodes or not. So I think initially you mentioned I think the previous speaker mentioned the BOLA trial, where that was a trial that showed that irradiating the lymph nodes also improved survival, but that was an old trial. So a lot of trials were done. The only trial that actually showed at least a metastasis free survival improvement was the Tata Memorial trial, but they did a PSMA PET, and so it was node negative after PSMA PET, and the PSAs, most of the patients had a very high PSA, above 20, and some into like 40. So it was like almost like the Stampede group of patients, but no mets and high Gleasons. So those patients, if you give nodal radiotherapy, there is an improvement in metastasis-free survival. Still, cancer-specific survival or overall survival was not really shown to be improved. Of course, in this prostate cancer, given the age of the patients and all that, it's very difficult to do a trial which will show overall survival advantage. You have to have a very large number then. So based on that, nodal radiotherapy is now given.
Dr. Gauri Bansal will move on to the next type of discussion. Okay.
Thank you, Devika, and the expert panel to have such a in-depth, detailed discussion and the presentation about the locally advanced prostate cancer. We are moving to the next presentation that's on the management of metastatic prostate cancer. Dr. Pragaladan, Senior Registrar Urology, is going to present it. And then I had a case scenario, but excuse me for not presenting in the slides. So this is the commonest prostate cancer patient we all see in Sri Lanka. So it's about 70-year-old male from Urumburai. He's a farmer, and he is initially investigated for a back pain for 4 months, and he has been with the orthopedic surgeon and general surgeon, and lastly end up in urologist with some storage LUTs. So there is no family history of prostate cancer in the family, and a digital rectal examination shows T3, and the PSA is 102, and the ultrasound scan is showing having a prostate's the post-residual volume is 60 cc with bilateral hydronephrosis, and his serum creatinine is 2, and he had a reasonably good urine output. And this is the case scenario he was presented with. I just kindly request Pragaladan to go ahead. How do you going to proceed from here? Give the appropriate investigation that would proceed to the diagnosis and the staging of the disease, and then the management plan. And then how do you explain the family on the prognosis basis with the evidence? Over to you, Pragaladan. Thank you.
Okay, thank you, sir. Shall I start my presentation, or shall I answer this question first one? I hope you all can see my slides. So good evening. So today I'm going to talk about the metastatic prostate cancer. So my next speaker will speak about that castration-resistant prostate cancer as well as the oligometastatic prostate cancer. So the patient can be, we can classify the metastatic prostate cancer. It can be a synchronous as well as a metachronous. In the both the patients can present is symptomatic as well as asymptomatic. As a management wise, we can classify into the hormone sensitive metastatic cancer and the castration resistant metastatic cancer as well as the oligometastatic prostate cancer. So the prostate cancer spreads through the bloodstream or the lymphatic stream. So the common sites include the bone, lungs, liver, brain, and the lymph nodes outside the pelvis, also considered as a metastatic lymph nodes. So the patient can, the metastatic symptoms such as mainly the back pain, so particularly in the pelvic ribs, skulls, and the spines, then unexplained weight loss, fatigue, anemia, and cough, breathlessness, and pruritic type chest pain, and constipation. So regarding the PSA level, with the PSA level, we can get the idea about that there is a chance of metastasis. Usually more than, if it is a PSA is more than 20, there is a highly chance of metastasis. So when the PSA level is more than 100, we need to think about the likely metastasis. About 71% patients get a metastatic prostate cancer. So regarding the M staging, so we can go ahead with the bone scans. The technetium 99 bone scans is a conventional imaging technique evaluating the distribution of active bone formation in the skeleton-related malignant and the benign diseases. It's having a sensitivity and specificity about the 79 and 82%. The bone scan should be performed in a symptomatic patient independent of PSA level, ISUP grade on the clinical stage. There are false positives may occur in patients with the fracture with the healing, and there is osteoarthritis. And regarding the fluoride PET CT and the choline PET CT, is 18 sodium fluoride PET or the PET CT, similar to the bone scintigraphy, only assess the presence of bone metastasis. The similar specificity and superior sensitivity to the bone scintigraphy. The choline PET CT also has advantage of detecting the visceral and the nodal metastasis. So the diffusion weighted whole body and the exoskeletal MRI are more sensitive than the detecting the bones, bone metastasis than the bone scan. So prognosis-wise, the prognosis of metastatic prostate cancer is it's about the median survival is about the 42 months, and the factors that determine this prognosis include the number and location of the bone metastasis, presence of visceral metastasis, Gleason score, ISUP grade, initial PSA, initial alkaline phosphatase, and the performance status of the patient, and the volume of disease. It depends on the charted and the latitude trials, and the metachronous metastatic disease. So it depends on the charted as well as the latitude. The charted, it can be divided into the high volume as well as the low volume. The high volume means it's for more than 4 bone metastasis, including the more than 1 outside the vertebral column of pelvis and or the visceral metastasis. And the latitude is considered as a high risk when the more than 2 high risk features of more than 3 or more bone metastasis, or the visceral metastasis and the ISVP 4 or more. So prognostic factors based on this work study. So the PSA after the 7 months after the start of androgen depressant therapy, it is less than 0.2. It's about survival 75 months, and the 0.2 to 0.4 nanogram per milliliter is about the 44 months, and more than 4 it's considered it's about 1 year. So management of metastatic hormone-sensitive prostate cancer is a first-line hormonal treatment. It's a primary androgen deprivation therapy has been the standard of care over the 50 years, and there are no high-level evidence in favor of specific type of androgen deprivation therapy for the oncological outcome, neither orchidectomy or LHRH agonist or antagonist. The level of testosterone is reduced much faster with orchidectomy. Usually, it's about 3 hours, and the LHRH agonist is about antagonist is about 3 days, and the agonist for about 3 weeks. And therefore, the patient impending spinal cord compression or the other potential impending complication from the cancer should be treated with the bilateral orchidectomy. So option when offering the androgen deprivation therapy, there are multiple things. So when considering the non-steroidal anti-androgen as a monotherapy, it's not recommended because it's less effective in terms of overall survival and the clinical progression. So considering the intermittent versus continuous androgen deprivation. So there nowadays is a continuous androgen deprivation is therapies become the standard of care. The early versus differ. There's an early treatment before the onset of symptoms is recommended in the majority of the patient with a metastatic hormone-sensitive disease, despite lack of randomized phase 3 data. The combination therapy is a combined androgen blockade with the old generation non-steroidal anti-androgens. So the systemic reviews have shown that the combined androgen blockade using non-steroidal anti-androgen appears to provide a small survival advantage versus monotherapy. Generally, the combination with the non-steroidal androgen should be only be considered if other combination therapies are not available. So the androgen deprivation therapy combined with the chemotherapy, so according to the charted trial, the beneficial effect of the addition of docetaxel to androgen deprivation therapy is most evident in men with the de novo metastatic high volume disease. So the systemic review, meta-analysis which included these trials was the addition of docetaxel to the standard of care improves survival. The absolute improvement in a 4-year survival of 9%. So based on these data, the upfront docetaxel combined with androgen deprivation therapy was considered as a standard in men presenting with the metastasis at the first percentage. So combination with the ARPI, arbitronolactamide, so they are randomized control trials. So that's the TRAMP and the latitude is the addition of arbitron acetate plus prednisone to androgen deprivation therapy in men with metastatic hormone-sensitive prostate cancer. This shows a significant overall survival benefit. There is about this tables, so it's about the significant overall survival with the STAMPEDE and the latitude who are treated with the ARPA. The combination with the docetaxel and the ARPA, the phase 1 trial shows that addition of arbitron to the androgen deprivation and the docetaxel has been reported benefit in a recurrent progression-free survival and in the overall survival. That this triplet therapy could be the become the standard of care for these kind of patients. The treatment selection and the patient selections, there are several meta-analyses of published data concluding that the combination therapy is more efficient than the androgen deprivation alone, but none of the combination therapies has been clearly proven the superior over another. So as a consequence, the patient should be offered combination treatment unless there are clear contraindication and very short life expectancy. The choice will depend on the fitness for the docetaxel, nature of the disease, and the patient preference, and the specific side effects, and availability, and the cost. The treatment of primary tumor in the newly diagnosed metastatic cancer, the first reported trial evaluating the prostate front radiotherapy in men with the metastatic castration-sensitive disease was the HORA trial. The following the results from the chart, the low volume subgroup, there was a significant overall benefit with the addition of prostate radiotherapy, and this STAMPEDE trial confirmed that benefit of prostate radiotherapy in patients with less than 3 bone metastasis. And therefore, radiotherapy of the prostate only in patients with a low volume metastatic disease should be considered. It is not clear that these data can be exploited through the radical prostatectomy as a local treatment. Results of ongoing trials are awaited. Is a flow chart of the patient with the metastatic prostate cancer. So we can consider the androgen deprivation therapy. Then if it is a adequate life expectancy, we can divide it in the high volume or low volume. So if it is a high volume, the patient is fit enough to go for a docetaxel. We can upfront double combination with the docetaxel, or if they can consider the upfront triple combination with the docetaxel, arbitron, and the androgen deprivation therapy. So follow-up, it's important to counsel about the early signs of spinal cord compression and blood outlet obstruction and the bone pathological fractures. So the interval of follow-up should be guided by the patient complaints, and it can vary. For the M1 disease, we can usually follow up about every 3 to 6 months. So PSA monitoring for the patient with the androgen depression alone, the PSA decline to less than 4 nanograms suggests likely prolonged response, and follow-up visits may be rescheduled every 3 to 6 months. So the rising PSA should prompt the assessment of testosterone level, which is mandated to define the castration-resistant prostate cancer. So imaging is a marker of response. So so 1 in 8 men with the PSA less than 2 shows the clinical progression. So the optimal timing and the image modality to be used remain unclear. Regarding the palliative treatment, the patient can present with the critical issues of palliation here there must be addressed when considering the addition of systemic treatment, including the bone pain and the constipation, anorexia, nausea, and fatigue and depression. The common complication due to the bone metastasis, patient can present with the painful bone metastasis. We can consider the radiotherapy, local radiotherapy. So the patient can present with the pathological fracture with the cord compression during that time. So we can start with the high dose of corticosteroids. We can get and the immediate MRI spine with get the orthopedic or the neurosurgical opinion on the decompression plus fixation, followed by we can control the radiotherapy. So regarding the urinary retention, the patient can be due to the secondary or stricture or the clot retention, so that we can consider the channel TRP. For the stricture, we can consider the ureteral dilatation. So that if it is a ureteric obstruction, we can consider the retrograde and antegrade stenting with PCM. So and the rectal complications, we can consider the dilation.
So thank you, Pragaladan, for the detailed presentation about the management of metastatic prostate cancer. And the expert panels is available, Manjula sir and Rad and Sagar also. So over to you, sir, to some questions and truthful discussion about our common cases.
Pragaladan, you were given a case scenario. So do you have any plan for that patient Dr. Gauri presented?
Yes, the patient was a 70-year-old farmer. He has a patient. He had his investigated for the back pain, then found to have a LUTS, and clinically there's a malignant prostate. So I can't remember the PSA levels. I think
102, yeah.
102.
102, yeah.
102. So the PSA is 102. So there's a highly chance of likely a metastatic prostate C. So and as well as he had a severe back pain also. So during that time, so I will order the bone scan as well as the truss biopsy. So depends on the bone scans, I will consider that management. So it depends. It's a bone scan.
What are your views of doing a truss biopsy when the PSA is more than 100?
So anyway, so even though with the PSA is there is no confirmatory diagnosis of I will go ahead with the truss biopsy as well as to confirm the diagnosis.
Okay, so you want to get some features of the malignancy before considering treatment?
So I can start the treatment, sir, but anyway, when we are at getting a consent for any kind of treatment, so we need a confirmatory diagnosis. So that's why I prefer the truss biopsy also, sir.
Okay, right. Suppose you investigate this patient and there are only 3 bony mets on the bone scan, 3 in the axial skeleton. Patient is having lower ureteric symptoms, or he's now on catheter, bilateral hydronephrosis.
Yes.
Is there a place for radical prostatectomy?
Yeah, so it can be due to the oligometastasis.
Let's say he's a fit and healthy farmer.
Yes, it can be maybe a oligometastasis. So in that conditions, there is option for the radical prostatectomy. So, but anyway, I need to do the advanced imaging. So anyway, the staging is imaging with the CCD chest abdomen pelvis to exclude any visceral metastasis. Then if it is even though then there is only oligometastasis, there is option. So we can go ahead with the radical surgery or radical treatment radiotherapies.
Okay, good. Nurad, any question?
Yeah. So moving on, I mean, your case scenario, so it's a backache. I think I'm sure you would. I mean, we see this in our setting, patients coming with cord compression, presenting with spinal cord compression. So any patient with backache, and you suspect prostate cancer, I think first step will be to exclude, look for features of impending spinal cord compression. So I think maybe an MR spine would also be relevant. And also when you're doing the staging workup, important, if you're doing a bone scan, then bone scan is important, but CECT also, because there can be lymph node mets, and so always do both. And so now you said that you are classifying prostate cancer into metachronous and synchronous and oligometastatic and sort of high volume disease and so on. So which group has, so if there are like 4 groups, so which group has the best prognosis and which group has the worst prognosis?
So the patients who are with the low volume with the hormone sensitive having a good prognosis. So
yeah, so low volume, is it metachronous low volume or synchronous low volume? Which category would have a better prognosis?
I think so metachronous is more good prognosis than.
Yeah, so metachronous is has a better prognosis. So in fact, one of the problems in the STAMPEDE trial, from which we get most of the evidence for the management of prostate cancer, metastatic prostate cancer, is that it has lots of de novo metastatic patients and very few sort of metachronous patients who develop metastasis after local treatment. So you mentioned about triplet therapy. So which category of patients would you offer this triplet therapy of androgen deprivation, anti-androgen, and chemotherapy?
So usually patients who are with the high volume disease, I am considering the triplet therapy.
Yeah. So high volume de novo metastasis or synchronous patients, you would consider if the patient is fit. Now at the moment, you mentioned the PEACE-1 trial. So that trial, what they did was the 2 arms was ADT plus docetaxel versus ADT plus docetaxel and abiraterone. So right now the evidence is that if you are giving abiraterone, if you think the patient needs, if you are giving docetaxel, if you think the patient needs chemotherapy, then adding abiraterone or adding an anti-androgen a novel anti-androgen will improve survival. So if you think your patient needs upfront chemotherapy, then you should be giving triplet therapy. But we don't know whether the other way around, we don't know. Say ADT plus abiraterone versus ADT plus abiraterone and chemotherapy. That has not yet been tested. So what we definitely know is that if you are giving chemotherapy, you need to add abiraterone, but we don't know whether abiraterone and ADT, adding docetaxel to abiraterone and ADT is necessary. That we don't know. So triplet therapies, now earlier docetaxel was used only in the castration resistant phase. Then after STAMPEDE, the first STAMPEDE reports, it came back into the hormone sensitive phase. And now again, it is slowly getting pushed out from the hormone sensitive phase to the castration resistant phase. So we would be using triplet therapies in very selected patients. But the other categories, you would, like oligometastatic, like even de novo or metachronous oligometastatic cancers, you can just manage with ADT and abiraterone. So even metachronous high volume disease, some would just go for ADT and abiraterone. Chemotherapy with docetaxel, we don't know whether triplet therapy is, of course, you have to take it case by case, but we're not sure whether the triplet therapy will be beneficial in that setting. Now, is there a group where we could just give ADT alone? I mean, which used to be the standard of care until very recently.
So patients who are not fit enough to go ahead with these kind of treatments, or
yeah, and also
short life.
Yeah, so you have to take it case by case. Yeah, not fit, particularly those metachronous oligometastatic cancers who are not fit for any sort of escalated treatment, that group you can just manage with ADT alone. And so I think Manjula sir also asked this, so touched on this. So what is the benefit of treating the primary tumor in metastatic prostate cancer? And in which patients would you do that?
Yeah, so it's a patient with a low volume disease with oligometastasis patients. We can consider the radical treatment with the radical prostatectomy as well as the radical or radiotherapy. So,
Yeah.
so it can improve the local symptoms as well as it will be improve the overall survival also.
Yeah. So the evidence is for radiotherapy, again based on the Stampede trial, and where they did a sort of a post hoc analysis, but it was sort of a fairly good post hoc analysis. So again, oligometastatic prostate cancer, if you treat the primary with radiotherapy, there is evidence. And the theory is that if you sort of sterilize the primary, it will stop the primary tumor shooting out more cancer cells that go on to metastasize. So that's the theory. But I suppose there is evidence, other evidence, although not in the form of a randomized trial, you can certainly consider radical prostatectomy, particularly in this the patient that you described, where there is a need to improve local symptoms also. But you should be mindful that these are advanced cases, so you will likely have it might be infiltrating the seminal vesicles and all that. So it's not there'll be local. The tumor might be locally advanced as well when you go for the radical prostatectomy. And also with regard to defining oligometastatic disease, now the Stampede trial and all of the trials did not have PSMA PET. So the definition of less than 5 metastasis and at least one outside the pelvis and spine, it relates to only conventional imaging. So it's bone scan and CT. So if you do a PSMA PET and you find these multiple sort of deposits that are seen on a PSMA PET but not on a conventional imaging, again there is this issue of is it really oligometastatic, or do you classify as high volume or not? So that's one of the problems. So the definition you'd still go by conventional imaging. Yeah. Yeah, that's about what I have to ask. Yeah.
Okay.
Okay.
Thank you.
Yeah,
Thank
can I?
you.
Yeah. Can I add something?
Yeah. Go ahead, Sagara. Sorry.
Yeah. Hi, Pragaradan. Yeah. Good presentation. So, I mean, when you're talking about metastatic prostate cancer, I think the other important thing you should talk about is about the treatment side effects, especially the androgen deprivation side effects, and how do you counsel a patient. So I wonder whether I missed anything. Did you talk about any side effects of androgen deprivation?
My first presenter here has talked about that pharmacological management.
Okay, sorry, I missed that bit. Okay, yeah. So I mean, anyway, I'll forward that question to anyway. How do you counsel? I mean, now you talked about metastatic prostate cancer. So how do you counsel a patient before you start hormones?
Yeah,
before you offer orchidectomy in Sri Lankan setting.
Yeah, so because it's when we are considering that hormone medical castration is in Sri Lanka, it's a highly expensive. So we can go ahead with if it's LHRH agonist or antagonist. The gossamer injection is cost about, I think it's about 50,000 monthly injection. So but when considering the orchidectomy, it's easy, but the problem is irreversible.
Yeah.
So when considering mainly the side effects are the patient can with the loss of libido and the hot flushes and mainly the anti-androgenic effect.
So what they are like, I mean, to label hot flushes.
Hot
Yeah.
flushes and loss of libido, erectile dysfunction. These things can happen. So,
What is the important things like in regard to bones?
yeah, the bone, the patient can develop osteoporosis.
Yeah. And any other sort of risk of cardiac events?
Yeah,
Because
there's a
reason for this question is like, it's a very common FRCS Viva question. So, you know, be counseling a patient on starting hormone treatment. And even sometimes, you know, you might, so at what point you start hormones, like, or even to consider orchidectomy, sometimes, you know, just for the presentation with a bone metastasis, do you still sort of go ahead with hormones, or what's the sort of a like newest thinking pattern? I mean, the thinking pattern now, are we
So early, they saying that the early treatment is better than the deferred treatment, sir, because it will increase overall survival as well as the disease progression, sir.
Yeah, in regard to, okay, so suppose if you get a patient who was started on hormones for metastatic prostate cancer, and he had good results with his PSA. So it was PSA 1000 when he started, and then it come down to less than 20, but he has got significant side effects of treatment. And now after about 6 months of treatment, he's coming to his 80-year-old. Okay. So he's coming to you with hot flushes and the osteoporosis, fatigue, depressed. So now what could you do for him? Like what advices, or what are the things you can do? He had a good response to hormones initially.
So we
I mean, even others can answer. I mean, not only Pragaladan, so even the other candidates can answer.
So we can use other type of drugs as considering that androgen receptor blockade, or there are some few drugs which can containing that less side effects than the other one.
We can consider continuous. There's something called intermittent androgen blockage versus continuous androgen blockage. So we can consider intermittent.
Yeah, you can consider intermittent, androgen blockage. So that's a good, it's an MCQ as well. So yeah, it's a good option too, because he had a good response with hormones. So you can now stop his hormones and then wait with the PSA surveillance, like 3 monthly PSAs. And if the PSA, like, I mean, there's no hard and sort of set guidelines, but you can wait for about PSA of the 20 and then restart hormones. And so you can go for intermittent androgen blockade. Yeah. Okay. So the other last question. So this is again a famous Viva question, and this is the only sort of emergency in the prostate cancer, sort of like, okay, when you get a patient with metastatic prostate cancer with spinal mets and possible cord compression, and so you need to sort of know to answer this as in a Viva scenario as well. So how do you sort of approach? You mean like list out a couple of things that you're going to do? Just take about 1 minute and we'll finish it off.
So it's a one of the surgical emergencies. So where I need to consider that doing a MRI spines as immediately to assess the level of the disease as well as the regions. As then I will get the oncological, orthopedic as well as a neurosurgical opinion on the possible decompression with the fixations. Then immediately I can start the steroids, the methylprednisolone. So if it is already not done any orchidectomy, I can consider the bilateral orchidectomy, which we can give a immediate response. So during that times I can make sure the patient go ahead with the decompression with the fixation. So if it is not possible, the patient not fit enough go for a surgery, so I can consider the giving a local radiotherapy to the sites.
So the local radiotherapy, for what you give actually, is that what's the benefit of the local radiotherapy?
So it will it can reduce the cord compression, so it can improve the
mainly you consider radiotherapy for bone mets to reduce the pain actually.
Yes.
So I mean, in addition, so I mean, yeah, it's true. Like, you are familiar with the orchidectomy, but I think as if you are sort of sitting for when I'm sitting for the FRCS exam, I think you need to consider the other team coming from the UK or the West as well. I think it's better to talk about an androgen, LHRH antagonist as the first option, because the orchidectomy, yes, if we do not have that again, but I think you touch about that as well, because still in MCQs and all, I think that is the answer. If it's a suppose best of 5 like question, if you have both options of orchidectomy and androgen antagonist, so answer should be antagonist. So that's the one we consider. So, and do you know the dose for degarelix? What is the dose?
Yeah, I can't remember the dose, I think.
Anyone, the other people? Any idea? So it's 240, but it comes in 120. So you give 2 injections of 120 and then followed by 80 milligram monthly or 28 days. So these all are, I mean, the MCQ questions, even the degarelix dose you need to know, because that's an emergency, emergency drugs, you need to know the doses as well. So just concentrate on that matter. Okay. Yeah, orchidectomy is an option, but is the last option here in this setup. But yes, it's the first option you'll consider, but keep in mind about the degarelix. Yeah. Okay, so
Yeah. Yeah, on that note, I think, yeah, a very important scenario. Also, MR, when you're doing the MR spine, I think at least in the oncology exams, you have to mention MR whole spine, because there can be other levels of compression. So make sure it's important to visualize the whole spine. You can have at multiple levels, and that might impact on surgery. Yeah, and also, we generally would start high dose steroids at diagnosis, but yeah, before you, I mean, at the same time, you prefer to neurosurgery. Yeah, radiotherapy is generally given only if it's sort of, I mean, you can give it after decompression, but it is only given if the neurosurgical team feels that surgery is it's not sort of not possible. So that's for spinal cord compression, surgery is the mainstay. Radiotherapy, we would give it as sort of if surgery is not possible. Also, one other important thing. So, what is the place of zoledronic acid and in prostate cancer? When would you use it?
If it is a patient,
Metastatic prostate cancer.
so if it is a patient complaining with severe back pain, and it may reduce bone resorption. So it will
Yeah.
reduce
Okay,
the skeletal related events in.
Yeah, no, would you, yeah, so, okay, so as an osteoporosis protection, you would use it, yeah. But if you're giving it as a sort of a bone metastasis, would you give it, when would you give it? Yeah, so there is no evidence. Stampede trial, they also randomized with docetaxel. They looked at zoledronic acid upfront for hormone sensitive metastatic prostate cancer, and there was no benefit. The evidence is only for use in the castration resistant phase. So if it's hormone sensitive metastatic prostate cancer, there is no place for zoledronic acid unless you're giving it like as an osteoporosis sort of protection thing. Then you give it like once a year. But the 3 monthly or the 3 monthly dose, you don't give it at during the hormone sensitive phase.
Thank you, sir. Because of the time factor, you might have to move to the next presentation, sir. Gauri, sir.
Yeah, thank you. Thank you very much. Thank you for the discussions. It's very hard to find a case scenario in between oligometastasis and the metastatic disease. I managed to get one. So our next presenter is Upul Indrajit. is going to talk about the oligometastatic and the castrate-resistant prostate cancer. I had a scenario to say that a 68-year-old male is a clerk in the government sector, investigated for the bloods, have no history of prostate cancer in the family. The routine digital rectal examination, it's found to be T2C, and his PSA is 30. And ultrasound scans shows the prostate volume is 50 cc with the PVR 50/230. So it's the same scenario, but the prostate, the PSA level is the different one. So I'm over to Indrajit to discuss about what you do and how do you going to proceed, and the presentation for the castrate-resistant prostate and the oligometastasis. Over to you, Indrajit.
Thank you very much, sir. So I'll present my presentation, and then I'll go into the case scenario. So I'll press share my slide. Okay, so my presentation is related to oligometastasis and castration-resistant prostate cancer management. So I'll first discuss about the oligometastasis prostate cancer, and then move on castration-resistant prostate cancer management. When considering the oligometastasis management, defining oligometastatic prostate cancer is still a doubtful thing. Currently, there's no definitive consensus exists regarding what oligometastatic prostate cancer is. Most commonly, oligometastatic disease is determined by the number of detectable metastatic lesions on conventional or advanced imaging. Many of the early retrospective data attempted to define oligometastatic prostate cancer using various number of bone lesions as the key inclusion criteria. With the current level of evidence, a general definition of oligometastatic prostate cancer can include patient with 5 or fewer metastatic lesion in the bone or lymph nodes, mainly considers involved bone lesions. So what's the importance of this definition of oligometastasis, then I will discuss. The difference is mainly evidence between high volume and low volume metastatic disease, which is oligometastatic state. According to the chartered trial, they did perform subset analysis on high volume and low volume metastatic castrate sensitive prostate cancer patients. They define high volume disease as 4 or greater bone metastasis with at least one lesion outside the axial skeleton or any number of visceral metastases. Patient with high volume disease had statistically improved survival when docetaxel was used in combination with ADT when compared ADT alone. This improvement in survival was not seen in the low volume cohort, which means the oligometastasis disease. This provides an interesting surrogate definition for what defines oligometastatic disease and change the management of these patients. So the treatment of the chemotherapy and combined with the ADT has not shown significant overall survival in oligometastasis disease. So the management is mainly in oligometastatic patient is local treatment, which includes the surgical or radiotherapy. In considering the role of local surgical treatment, the cytoreductive radical prostatectomy is the local surgical treatment for the oligometastatic prostate cancer. The local surgical therapy in oligometastatic prostate cancer primarily achieve an improved survival benefit by controlling the primary tumor. Also, it reduces the local regional symptoms of the patient. The existing data is mixed regarding local surgical therapy in selected oligometastatic prostate cancer. While some retrospective and population-based data point to improved progression-free survival and cancer-specific survival, the only prospective data, which is not randomized, fail to show the same survival improvement with the surgical therapy to the primary tumor. So the surgical therapy alone, as a sole treatment, has not shown significant outcome in validated data. And many clinical trials are currently ongoing and hope to answer this very question, which include the RAM trials of 1802 and trombone trials. So they are still not published. With the evidence, we may have to, with the evidence, it will change time. And the other available option for the oligometastatic disease is the local radiotherapy. Similar to the local surgical treatment, the data to support radiotherapy to the local tumor in oligometastatic disease is also mixed. But established data regarding radiotherapy is higher quality than the surgical data. So it's the radiotherapy is considered with improved treatment. So multiple guidelines include the NCCN, EAU, and UK NICE support the use of radiation to the primary in low volume oligometastatic prostate cancer patient. This is further supported by the recent advanced prostate cancer consensus statement of 2019, which also support the local radiotherapy as higher high treatment value. So then I will move to my next topic, which is the castration-resistant prostate cancer. So I'll first define the castrate-resistant prostate cancer, which is castrate serum testosterone less than 50 nanogram per deciliter or 1.7 nanomole per liter, plus either biochemical progression, which is defined by 3 consecutive rises in PSA at least 1 week apart, resulting in 50% increase over the NIDA value and PSA more than 2 nanogram per milliliter. Another thing is the radiological progression, which is evidenced by the appearance of new lesions, either 2 or more new bone lesions on bone scan or soft tissue lesion using response evaluation criteria in solid tumors. Castration-resistant prostate cancer has 2 arms, which is a non-metastatic and the metastatic. So, in considering the non-metastatic castrate-resistant prostate cancer management, they have to evaluate the patient. So, the frequent PSA testing in men treated with ADT has resulted in earlier detection of biochemical progression. Of these men, approximately 1/3 will develop bone metastasis within 2 years. Which is detected by conventional imaging, include bone scan. In men with castrate-resistant prostate cancer and no detectable clinical metastasis using bone scan and CT scan, we can use the baseline PSA level, PSA velocity, and PSA doubling time to assess the first bone metastasis and bone related metastasis-free survival and overall survival. These factors may be used when deciding which patient should be evaluated for metastatic disease. So the consent statement by the PCA radiographic assessment for detection of advanced recurrence group suggested the bone scan and the CT scan when the PSA reached 2 nanogram per milliliter, and if this was negative, it should be repeated when the PSA reached 5 nanogram per milliliter. And again, after every doubling of the PSA based on PSA testing every 3 months in asymptomatic mode. But in symptomatic patients should undergo relevant investigation regardless of the PSA level. With more sensitive imaging technique like PSMA, PET-CT or whole body MRI, more patients are diagnosed with early metastatic castrate-resistant prostate cancer. But it remains unclear if the use of PSMA, PET-CT in this setting improves the outcome of patient. And considering the management of non-metastatic castrate-resistant prostate cancer, there are 3 large phase 3 randomized trials has been done, which includes the PROSPER, Spartan, and Aramis trials, which evaluate the metastatic-free survival as the primary endpoint in a patient with a non-metastatic castrate-resistant prostate cancer, which is MNOT CRPC, which has treated with enzalutamide in the PROSPER trial with versus the placebo, and apalutamide used in the Spartan trial with the placebo, and darolutamide used in the Aramis trial with the placebo versus the placebo respectively. So the MNOT status was established by the CT and bone scan. In these trials, only patients at high risk for the development of metastasis with short PSA doubling time of less than 10 months were included. Patient characteristics in the trials revealed that about 2/3 of the patients participant had a PSA doubling time of less than 6 months. In all these trials, they have showed a significant metastatic-free survival benefit. and overall, all 3 trials showed the survival benefit after follow-up of more than 30 months in non-metastatic cancer-resistant patients. So these are the trial summary, which at the end they have evaluated the metastatic-free survival and the progression and the death, the survival, overall survival. So the Prosper and Spartan trials shows that around 70% reduction of overall improvement of overall survival in comparing the using the enzalutamide and apalutamide. Then I'll discuss about the management of metastatic castrate-resistant prostate cancer. When treating when we treating these patients, selection of treatment for metastatic castrate-resistant prostate cancer is multifactorial and in general depend on previous treatment for the non-metastatic castrate-resistant prostate cancer and metastatic castrate-resistant prostate cancer. And also it depends on the previous treatment for metastatic hormone-sensitive prostate cancer and for and non-metastatic hormone-sensitive prostate cancer. And also depend on quality of response and the pace of progression of previous treatment and non-prostate between ARPI and the patient's co-medication and non-drug interaction, and also other factors which depend on treatment is the non-genetic co-interaction in microsatellite inhibitory pathways, and also non-histological variants and DNA repair deficiency, and local approval status of drugs and reimbursement situation, and also the available clinical trials and the patient comorbidities have to be considered when we are treating the metastatic CRPC. So also in treating these patients, the molecular diagnostic also important, and these patients should undergo evaluate for the MMR defects and also the microsatellite instability and germline testing for the BRCA mutation is also important. And when considering the treatment decision and sequence of available option in metastatic CRPC patient, approved agents for the treatment of these patients are docetaxel, arbitron with prednisolone, enzalutamide, cabazitaxel, olaparib, and radium 223. The use of chemotherapy, docetaxel, and subsequent cabazitaxel in the treatment sequence is recommended and should be applied early enough when the patient is still fit for the chemotherapy. So the summary of evidence for the prolonged treatment of castrate-resistant disease according to the EU guidelines is the first-line treatment for these metastatic castrate-resistant prostate cancer patient should be will be influenced by which treatment were used when the metastatic cancer was first discovered, and there were no clear-cut recommendation can be made for the most effective drug for the first-line CRPC treatment, as no validated predictive factors exist. And so they recommended to ensure that the testosterone, we have confirmed the diagnosis, and then the counsel manage and treat the patient with CRPC in a multi-disciplinary team, and treat patient with like prolonging agents, and offer MCRPC patient somatic for germline molecular testing, which I have mentioned previously. So the first-line treatments of metastatic CRPC includes the
Dr. Ugo, sorry to interrupt. You have 2 more minutes.
Okay, then I'll go through quickly. The first-line treatments include the abiraterone, enzalutamide, docetaxel. Docetaxel is the most commonly used drug, and is the first-line chemotherapy, which we use 75 milligram per square meter, 3 weekly doses combined with prednisolone 5 milligram twice a day. We can use up to 10 cycles, and it independent prognostic factor include visceral metastasis, pain, anemia, bone scan provision, and prior extramuscine may help satisfactory response to docetaxel. And other drugs, also there are other drugs which I'll go through the site quickly as there's less time permits. And second line treatments are the all patients who receive treatment for metastatic cancer, metastatic CRPC will eventually progress into the resistant cases. So high level evidence exists for second line treatment of the first line treatment for MCRPC with docetaxel or ARPI. There's carboxytaxel, novel taxane with activity in docetaxel resistance cancers, and abiraterone acetate after docetaxel also we can use as second line treatment, and enzalutamide after docetaxel also can use. And there's a treatment model called radium 223, which bone specific that is associated with the survival benefit. And this is the published data regarding the radium 223 use, which has a significant improved overall survival. And there are other first line hormone treatment after docetaxel and first line hormone treatment, which include the hormone treatment and radiopharmaceutical treatment. And after the treatment, we have to monitor the patient's response to the treatment. So we have to take the patient's history examination and baseline blood test, which include the PSA test, total testosterone level, and the patient's basic investigation, which include the full blood count and the liver function, renal function. And PSA level, PSA alone is not reliable enough for monitoring disease activity, because in advanced CRPC, visceral metastasis may develop without tracing the PSA. So the recommends a combination bone scintigraphy and CT scan. And
sorry,
PSA
Dr. Kul, 15
Yeah.
minutes, so you can rush through the slides and finish the presentation.
Okay. So there's 2 more slides. So the recommendation for systemic treatment of metastatic cancer is the castration-resistant prostate cancer of a patient with MCRPC who are candidates for cytorexic therapy and who are chemotherapy naive, docetaxel with 75 milligram per square meter every 3 weeks. It's a strong recommendation. And there's other treatments models, as I mentioned previously, which include the abiraterone, cabazitaxel, and radium 223. And also we can use upper chemotherapy to patient previously treated with abiraterone and enzalutamide, which are strong recommendations. So these are also the previous slide I have mentioned previously. Sorry for the delay.
Okay, thank you, Dr. Kul. Then we can move directly into the discussions.
Upul, you were given anyway, a good presentation, quite a lot of data to take. Gauri said about a patient who is having a minimal LUTs and who will be a candidate for oligometastasis. So suppose that patient is not very fit cardiac function wise, and he's suitable for a radical prostatectomy, but anesthesia wise it's dangerous. So according to the guideline, what would you offer him? Let's say he's having only 3 bone mets. PSA is 30.
So I'll discuss
Locally,
this
let's say CT3.
So I'll discuss this patient in MDT settings, and then the available options is as patient is not fit enough for radical surgery. Best available option is the radiotherapy.
So how do you offer? He has metastasis, so it is not a total local treatment.
Yeah, with the combined chemotherapy, added chemotherapy, which includes the ADT and the added chemotherapies.
Chemotherapy. I'm not sure about that, but added androgen deprivation therapy should go hand in hand. So your neoadjuvant ADT, then your radiation. Then would you treat the bone lesions? Well, there are 3 bone lesions, well defined on the bone scan. Would you use a different modality to treat the bone lesions apart from the systemic treatment? Well, if the patient is having pain in a particular lesion, you can offer him stereotactic radiotherapy to bone. Right. So let's say now you got that castration-resistant prostate carcinoma without metastasis.
Or live monitor, continuously monitor the other patient developer.
So what would you offer him? There is a castration-resistant prostate carcinoma, but metastatic screen reveals a blank. His PSA is coming up, but he's at a castration level.
So there may be sorry, I didn't get the question, sir.
There is a patient who is now, is in castration level of testosterone. That means less than 50 nanograms per deciliter. But his PSA is, worrisome. It's rising. So you diagnose a castration-resistant prostate carcinoma, but M not.
So I'll reevaluate him for the visceral metastasis, whether there's any visceral metastasis there. And if there are, then I have to go ahead and treat him with the my consult with my oncologist and starting the chemotherapy, sir.
Very good. Because according to the guideline now, if there are no metastases, there is no place for the abiraterone or enzalutamide. I mean, it will come in the future, but at present, that is not an option. Okay, right. So when you get to this castration-resistant prostate carcinoma with metastasis, so that is a quite a grave condition. So what is your treatment in this situation? Let's say he is having multiple bone mets. Let's say five bone mets, and the new ones are also appearing.
So in that case, it depends on the patient's previous treatments option, whether he has responded to the previous other hormonal treatment, and he's now is not responding to the castration as level. So I'll first start the docetaxel as its first line treatment, and I'll then follow up the patient with the PSA levels and the bone scans, regular intervals, and assess his treatments with the clinical, the biochemical, and radiological assessment. I will decide whether to go ahead with continuous treatment or stop the treatment at the time. Right.
But just a while ago, Dr. Nurad said, if you take a decision to start on a chemotherapy, then obviously abiraterone and prednisolone should be started along with it for a better outcome. So
Yes.
if you decide to go for the chemotherapy now, then adding this androgen receptor agonists are of some use.
Okay. Yes.
So that was the lesson we learned from today's meeting.
Yes.
Okay, Nurad, you can ask some questions.
Yeah, I think, so first thing is regarding local treatment of oligometastatic prostate cancer. I know this is a surgical audience and you are born to do radical prostatectomies, but the evidence, the clear evidence is for, I mean, whatever the evidence, the highest evidence is for radiotherapy for the prostate. You can consider radical prostatectomy if there is significant local symptoms which you think will improve. So, I mean, so offering radiotherapy because the patient is not fit for radical prostatectomy in this setting, the metastatic setting, I don't think that should be the case. Your indication for radical prostatectomy should be, or so-called cytoreductive prostatectomy should be significant local symptoms. That's number one. And interesting point you brought out, sir, about oligometastatic prostate cancer and stereotactic radiotherapy. Still, the evidence is a bit experimental, but a lot of centers are doing it. They're treating both the primary and the metastatic deposits, if there are very few, with stereotactic radiotherapy. So, and some of them don't even give androgen deprivation. But of course, your standard answer exams and so on should be androgen deprivation and treatment of the primary. Only the treatment of metastatic sites you can also mention, but some centers try to avoid ADT by or delay the onset of ADT by sort of treating all these oligometastatic deposits. And with regard to non-metastatic prostate cancer, castration-resistant prostate cancer, again, that is sort of an, I think Manjula alluded to it in the previous I think the second talk. So again, it is an iatrogenic disease really. If you go and start androgen deprivation unnecessarily, this is what you get. So that's why, so for example, after radical prostatectomy, of course, rising PSA, there is a clear indication to give adjuvant RT and hormonal therapy. But the other way around, say after radical radiotherapy, if the PSA starts rising, you don't need to treat unless there are metastasis on the scans. The problem happens when you when you initiate ADT just for rising PSA, and then you go on with ADT, and then the PSA starts rising further, and there are no mets, and you don't. So it's a sort of a iatrogenic disease. But having said that, there are the recent trials showed for enzalutamide, darolutamide, and so on. They showed a overall survival advantage also. So the only clinical situation where I think if you follow guidelines and you end up with this state of non-metastatic castration-resistant prostate cancer is when you are giving androgen deprivation after radiotherapy for either post-operatively or as primary treatment. So you give it for like 2 years, and during that 2 years, your PSA, while on androgen deprivation, your PSA can start rising, and you may not find any metastasis on scans. So there's evidence to, and these patients, there's evidence to switch to or include an anti-androgen, but again, guidelines are still not very clear because this is still a sort of a disease category where we don't, sort of a iatrogenic disease. Having said that, yeah, moving on to the castration-resistant metastatic prostate cancer. Now you clearly mentioned there is docetaxel, you have the anti-androgens. Now, again, you have to look at symptoms now. So docetaxel, in the castration-resistant phase, actually, if you look at the original trials, they only gave it for patients with symptomatic disease. So you should have significant symptoms like backache or worsening backache. So it's not just a rising PSA or not just your scans showing radiological progression. You should have symptoms. That's the category where you would then consider giving chemotherapy, because obviously chemotherapy is toxic. So and it's not curative. You're only going to prolong survival. So you don't want the treatment to be sort of worse than the disease. So in symptomatic patients, you would give docetaxel. So in this setting, you wouldn't really add abiraterone right away, although after docetaxel, it's very likely, your PSA is going to progress at some point, and you would then obviously have to give abiraterone or enzalutamide afterwards. But in the hormone sensitive phase, you would give it together. But in the castration resistant phase, you just give docetaxel. And so if you don't have symptomatic progression, but it's just radiological or maybe PSA progression, a lot of clinicians would not actually worry too much about PSA progression at this point. But if there's radiological progression, significant radiological progression, but minimal symptoms, then for these patients, we would give anti-androgens first rather than docetaxel, because they are obviously less toxic. So the patient doesn't have much symptoms. You don't want to give chemotherapy to these patients. You would rather give abiraterone or enzalutamide. So that's how the sequencing works. In this country, it's not available, but in the UK, they have radium-223, which is given if you have bone-only disease. So you shouldn't have any visceral disease. Castration-resistant prostate cancer with bone-only disease, you can give radium-223. Reasonably well tolerated, but it sort of can cause neutropenia and so on, because you're irradiating, and the bones get irradiated in the form of radiotherapy. given as a radioisotope. The other drug is cabazitaxel. That is, you give it after docetaxel. So you give anti-androgens and docetaxel, and still the patient is progressing and still fit to get chemotherapy. These patients you can consider the chemotherapy cabazitaxel. But it is now, because we are using docetaxel upfront, cabazitaxel is now coming into sort of use a bit more. But again, it's very, very challenging to give chemotherapy twice to a patient with metastatic prostate cancer. Yeah, otherwise, I thought the presentation was quite good and it covered all areas.
Okay, thank you very much, sir. Over to Sagar, sir. Is there any question for the candidates, sir?
Yeah, so yeah, it's very good presentation, but just a comment, like the good thing about castration-resistant prostate cancer, metastatic and non-metastatic. Can you hear me?
Yes, sir.
Clear,
Okay.
sir.
Yeah, good thing is actually very little or no questions at the exam from the castration resistant, especially in regard to the drugs, because we surgeons have a little brain and, you know, these all complicated and confused. I think we have the oncology team and Dr. Nurad and all for us to get that opinion. So it's a fair exam, surgical exam. Don't worry too much about this novel treatment and the treatment protocols for the FRCS exam, as even in the practical setup, you know, I mean, these are MDT and then you refer for the oncological sort of treatment. So that's the most important thing. Don't worry too much about them. But as surgeons from the castration-resistant, metastatic or non-metastatic, so what are the, as a urological sort of surgeons, the challenges you encounter? Upul?
So these patients may have this the normal scenario. They will have this the progression of the disease without the obvious PSA level and other things. Patient will be the castration-resistant patient will advance the disease very quickly. So they have the surgical, the complications related to the acute, the bone metastasis, and also the local complications will be very high. So we have
yeah. What are the local complications? Yeah,
due to the bladder outflow obstruction and with that related the high pressure, the chronic retention, and all the complications, as well as the bone related complications will be the disease progression will be very quick. So we have to monitor this patient with the multidisciplinary and treat the patient with the oncology support, as well as the palliative care we have to also discuss with.
Yeah, that's the sort of, you know, very important term. You need to use this palliative team in this, you know, managing a patient with palliative intention. So I mean, when it comes to bilateral ureteric obstruction and presenting with AKI, okay, so what are the options that you discuss with the patient? As a sort of, you are the one who actually see this patient. So what are the options you discuss, and what options you have actually to manage a patient with bilateral ureteric obstruction in a background of castration resistance and coming with AKI?
So it's depend on the patient's stage. Most of these patients are very the trial and with the short half-life. But the patients we have to also discuss about the patient's quality of life. So the available options are the by decompression with the radiological, the PCM is one option. Other thing is the endourological options with the catheterization and reduce the bladder outflow obstruction. But in these patients, they are very fragile, so and the anatomy will be also distorted. So I'll discuss the patients, the available options, and and also discuss the quality, the patient's quality of life. We have to balance between those things. So the main available options are those two, sir. I'll discuss with the patient and the patient's relatives. And the downside of the TCN is the pain, and also the patient will be difficult to continuously the dislodgement and other the dislodgement is also high with this the PCN insertion, but it is a relatively easy procedure with the radiology support without using this anesthesia. We also we not need to use the anesthesia. Other option is the suprapubic catheterization, but there will be the metastasis. It will be also a bit difficult, I think.
Yeah, I mean, you have to be realistic in this scenario. Like, you know, you need to be realistic, and doing nothing is an option. Like, I mean, after having a discussion, because, you know, I mean, how many months you are going to add to this patient by having nephrostomy, and also what is the quality of life you are going to offer. So these are the two things you need to consider. So, I mean, after sort of careful counseling with the patients and the relatives, I think going ahead with no treatment, because, you know, I mean, these are one mode of dying with a prostate cancer, so the AKI. So I think it's quicker and comfortable to die with AKI rather dying with bone pain and suffering and with the nephrostomy. So that's that realistic option you need to discuss in a patient who coming with this complication. Okay, so yeah, that's one thing. And what is a super scan? It's just a quick question. What is a super scan? Is it your super bone scan? Okay.
I have no idea.
Anyone else? Pagaladan, Tivika?
When there are multiple metastases, actually the bone uptake is more than it will be more than the soft tissue ratio.
Yeah, so I mean, yeah, there's hardly any the uptake or activity in the bladder and the kidney, as it all the traces are taken up by the bone mets. So when you have multiple bone metastases, you might see super scan. Yeah. Yeah, good.
Okay, thank you very much, sir. So
Yes.
now we are coming to the conclusion of Uromet session on prostate cancer, sir. Is there any question in the audience you can ask in this moment and get clarification?
There is a
So
question to me on
okay,
the chat box about PARP inhibitors and BRCA mutation testing. Yeah, that's a very good question. So after in castration-resistant prostate cancer, we don't do it in Sri Lanka very much, but in other countries they do check for BRCA mutations. You can do it, look for germline mutations, as well as you can look for mutations on the tumor specimen. And if these mutations are present, then you can give a drug called olaparib, which will improve, again, prolong survival. Yeah, so that's a good question. But it's very expensive, so not available in Sri Lanka for routine use.
Okay, sir. Thank you very much, sir. So today have been a very fruitful discussion for this Uromet 3.4. So
Sir, one more doubt.
okay.
One more doubt, sir. What is the play? Sometimes we even after that, to achieve the maximum androgen blockage, we are combining even after bilateral orchidectomy. Sometimes we are giving bicalutamate also. So what is your opinion? Because is it always must? So
Yeah, I think opinions will differ here, but my personal view is that it's I think the benefit is very, very small, and I personally wouldn't recommend it, particularly after orchidectomy. Even otherwise, so in the metastatic setting, we have newer androgens, we are combining abiraterone and so on, so there is no place for drugs like bicalutamide. So even in the adjuvant setting, there is no evidence for that. So even if you're going to go with ADT alone, the benefit of complete androgen blockade is very small, and if you weigh the risk benefits and everything, I don't think it's a I would personally wouldn't recommend it.
thank you, sir.
So other things, Tivika, you need to consider, I mean, where else the testosterone being produced?
That is usually because the theoretically because some small percentage comes from the adrenal, so we
Yeah.
can, even if we
Mm.
do the orchidectomy, the whatever comes from adrenal by giving this bioglutaminate, we can achieve maximum androgen blockage. That is the theoretical part, but I don't know.
Manjula sir, any opinion on that, sir?
Yeah, because Sagar then might as well do a serum testosterone level just to see
Yeah.
whether you have
If
got
it's
the
in the castration level.
yes, whether the level has been achieved prior to giving bicalutamide.
Okay, so then I would like to invite Manjula sir to have the conclusion and thanking our Nurad sir on behalf of Slaus sir.
So that is actually now today was the oncologist day. So if Nurad was not around, we couldn't have had a fruitful discussion. So it's like we have been into MDT. No? Going through large number of cases in MDT would have given the feeling that we have now. So we are, very grateful for Dr. Nurad Joseph to have taken time off his busy day and coming to, shed some light on the new developments and how best to manage this maze of various new medicines that is actually converting a hopeless disease into some survival. Even though it is few months, it is adding some survival. So on behalf of SLOUS and the Urology Committee, I thank Nurad for your excellent contribution, and also to Sagara who has joined us and who was very particular in asking what would the urologist do in this whole situation when there is so much of theory and various technical things, what simple things he can do as the urologist to improve the outcome. And I'm sure those will be the questions in the FRCS as well.
Exactly. Those are the questions actually. There's no point
Because
having.
examiners are not oncologists, so they are also urologists. They will keep on asking about the practical side of it.
And you fail on the simple matters, not on the hi-fi stuff.
Yeah, that's why I'm not trying to sit the FRCs this time. So now Gauri Bhavan and Niranga arranged this two or three case scenarios. But I was thinking the speakers would, address those three examples to give their opinion, but they ran short of time. So till we meet next week with another episode of the Uromet 3.0. So we thank the expert panel, Nurad and Sagar, and the two moderators and the speakers for keeping the discussion alive by good preparation and having a wonderful presentation. And thank you for all the participants. Have a nice evening. Good night. Thank you.
Thank you, sir. Good night, sir.
Thank you for inviting me. Thank you.